Good evening, and thank you everyone for tuning in tonight to our live stream event. We're excited to bring this to you, to your home or wherever you might be tonight. My name's Dr. Jonathan Fallon. I'm the Chief of Orthopedic Surgery at Cooley Dickinson Hospital, an orthopedic surgeon here at Cooley Dickinson Orthopedics and Sports Medicine. We're excited to have Dr. Brian Hoffman here. He's joined our team at Cooley Dickinson Orthopedics and Sports Medicine, and it's my pleasure to introduce him as tonight's speaker. For those of you who don't know Dr. Hoffman, he went to medical school at Mount Sinai School of Medicine in New York City, where he also did his internship. He subsequently did a residency in the Department of Orthopedic Surgery at Maimonides Hospital in Brooklyn, New York. He also did a research fellowship while he was there. And then after that, went down to Durham, North Carolina to do a foot and ankle fellowship at Duke University. Prior to all that, he went to undergraduate at University of Rochester, where he graduated with honors. So Dr. Hoffman's been in the area for well over a decade, practicing at Bay State Franklin Medical Center, but we are lucky enough to have him join our team recently at Cooley Dickinson Orthopedics. So without further ado, I'll give you to Dr. Hoffman.
Hey, all right. So here we are. Thank you so much, Dr. Fallon, for that introduction. Appreciate it. Pretty excited to be here. I want to thank Cooley Dickinson Marketing for putting this all together. And I just want to say that I am new to video conferencing. So hopefully we worked all the kinks out. The tech support here is fantastic, and we have a lot of interesting things to talk about. And so let's see if we can get this going here. Great. So if it all worked out okay, that's me in the upper left-hand corner. My name is Dr. Brian Hoffman. I'm an orthopedic surgeon working for Cooley Dickinson Healthcare, Orthopedics and Sports Medicine. And the title of today's talk is From Bunions to Breaks, 5 foot and ankle ailments explained. Hopefully we picked some ailments which are common to at least some people, or at least have interest in some people out there. There are a lot of attendees, I understand. And at the end, we'll have time for some questions and answers. My spiel will be about 30 to 40 minutes. And then if you have questions anytime throughout, we're not going to take a break for questions, but I was asked to let you know that there is a box on the right-hand side of the YouTube player. So just make sure to type your questions there. We have a great team in the room here who can pass those questions on at the end. So a little bio about myself. After medical school, we do a thing called a residency. So I did residency training in orthopedic surgery, did some research there, and then did a fellowship in foot and ankle surgery. Very interested in the foot and ankle, as you'll see, I hope. And we also do things, and I do things in addition. We do joint replacements and general orthopedic surgery, but the focus of today is foot and ankle surgery. And I've put up the contact information for our practice, and we'll have that again at the end for people who, through your primary care doctor or yourselves, want to give us a call and have us try to help you out. So let's move on here. I do need to throw up a couple of disclaimers. Number one is I have no financial relationship with any industry or company in healthcare. So there are no reimbursements or retainers. I have no biases in that way. Image sources, I will have some photographs and pictures, and they don't constitute any endorsement of the things that I'm showing pictures of. There's no relationship there. And finally, I do want to just make sure that everybody knows that medical information I provide is just in general informational terms. It may not apply to you specifically. If you have any specific medical questions about yourself, come on in and we can certainly check it out. 10,000 foot view of what we're going to be talking about today. First, pain in the ball of the foot, very, very common. Second, we're going to move up the foot to bunions, also very, very common. Third, we're going to move to sort of a foot and ankle deformity problem experienced by a lot of people called a flat foot, which many may have heard of. Moving further back to the Achilles tendon, and then finally, since it is bunions to breaks, we're going to be talking a little bit about a broken ankle, hopefully affecting very few of you and none of you in the future. So just a little background about the foot and ankle. As you can see from this animation, there are a lot of bones in the foot and ankle. It's about 25% of the bones in the human body are in your feet and ankles. That's a lot. It's asking them to do a lot. 16% of the joints in your body are found down below your ankle. And in spite of that, the amazing thing is the ankle surface area is only about 0.8 square inches. So not even a square inch with each footfall on each ankle. And the amazing thing about that is ankle arthritis by itself is really, really uncommon. So there's something we still are learning about how the foot and ankle holds us up. The foot is designed to be flexible and rigid depending on what it's doing. Anybody who appreciates a flexible foot will understand that when you're walking along a sandy beach or a rocky surface or a hilly slope, right? You want your foot to adapt to what it's landing on. And all of a sudden, as you move forward, it has to suddenly get an arch and become rigid and propel you to the next step forward. So it's really an amazing part of the body. Some certain problems of the foot and ankle often go together. So we look for things like a flat foot with a bunion or a high arch with pain in the ball of your foot. So that helps me figure out what may be bothering you. And in general, those things that bother you can fall in 3 different categories. The first is malalignment. And you can see that some of those malalignment things can get a little bit unusual. You can see this patient of mine had some feet which were photogenic for more than just a malalignment problem. An overload problem, and those are often related. And you can see how certain environmental stimuli can make a foot feel pretty overloaded and beat up. And then finally, degeneration problem. This little graphic just shows arthritis of the big toe joint, which is a very common place that wear and tear can happen in the foot. So there are other things that can bother people. There are other problems outside of those 3, the big 3 we call them. Late consequences of injuries like arthritis, autoimmune inflammatory problems like rheumatoid arthritis, psoriatic arthritis, autoimmune diseases, infections, even atypical infections. You may have heard of Lyme disease around here. That can affect the joints, crystal diseases like gout, and even tumors. Now, a lot of people come to my office with a swelling or a lump, and they're worried that it's a tumor. And well, I'll let somebody else tell you what I tell them.
I have a headache.
It might be a tumor.
It's not a tumor. It's not a tumor at all.
Yeah, so nobody says it like Arnold. It's typically not a tumor. I just want to reassure you that almost right out of the gate. So pain in the ball of the foot. Let's start with the first one. It has a medical name. It's called metatarsalgia. Metatarsalgia means pain. Metatarsals are the names of those long forefoot bones here. And pain across the ball of the foot is called metatarsalgia. It's an overload problem typically. So when you're spending a lot of time on your feet or when you first get on your feet after resting your feet, that pain across the ball of the foot can really bring you down. Sometimes it does go together with other problems like a bunion. When the big toe moves over, it's really not doing this job holding up the inner ball of your foot. So that weight is transferred to the outer ball of your foot and it can hurt a lot. Claw toes for the same reason. I'm going to move over here and show you with my hand. If the toes come up, that tough, fibrous, fatty piece of tissue that we normally walk on moves forward out of the way, and you can really beat up the ball of your foot right on those bones. And there are ways to treat that, usually non-surgical, but it can really be a problem, especially as we advance in age and those tissues become a little thinned out and less tough. Often that metatarsalgia can be associated with calluses and corns and thickening of the skin, and sometimes those calluses and corns can be a clue as to where that overload is happening, right? If you take a look at this picture of a patient of mine's foot and x-ray, it's pretty obvious where that overload is happening. That corn, that callus on the bottom of the foot is a sign of what's going on. If you take a look at that x-ray, and we get x-rays all the time in my line of work, you can see that that metatarsal bone there, and I'll highlight it right here, is longer than its neighbors, much longer in this case. And if you remember that metatarsals angle down towards the floor, a longer metatarsal presses harder against the floor. And that can lead to an overload pain and a callus. And it is true that surgically I can shorten that metatarsal and relieve you of pain there. But most of the time it doesn't come down to that. Most of the time with a good insert or a pad that goes around there, you can relieve that pain. That callus will just melt away. So there are other problems in the ball of the foot besides just pure mechanical overload. This is a picture here, a graphic of something called an aroma. Many people have actually heard of a Morton aroma. In fact, many people have seen me for a Morton aroma that's had a shot or something that just still hurts. It was described by a guy named Morton in 1876. And I like to mention that he didn't mention that it was also described 30 years before him by a guy named Durlacher, who was in Queen Victoria's medical team. So 30 years later, Morton came up with it. We call it a Morton aroma, and it affects women much greater than men for reasons we don't understand. It may have to do with classic footwear. That incidence is actually changing, and you can see here that narrow shoes that squeeze your feet might not leave room for everything the foot was built to have, including that nerve. So if you have pain in the ball of your foot and maybe some tingling or burning or even numbness between the toes, that can be a Morton aroma acting up. And there are both operative and non-operative ways to cure you of that pain. Most of the time, that insert here with a little pad behind where that weight is happening can really help, really make a difference. So moving up to bunions, you can see here that there are these red bumps on the inside of the feet, right near where the big toe starts. That is a bunion. How that problem happens, we still don't know completely. It is absolutely true that DNA has something to do with it. The apple doesn't fall too far from the tree, as everybody knows. But it's also true that that's not the only story. This problem is relatively uncommon in societies like tribal societies where footwear is uncommon. However, what we do to our feet, there's no doubt, has something to do with it. It doesn't take a mechanical engineer to recognize that these shoes are not shaped like your foot. And lest anyone think that I have any kind of a bias against traditionally female footwear, there is absolutely a problem across classic gender definitions in terms of what you wear on your feet and the consequences it can have. So the problem also is that it's not just a bump, as these shoes will tell you, it's an alignment problem, right? In fact, we don't typically call it a bunion, although you can certainly call that bump a bunion. It's called, in my line of work, hallux valgus. Hallux means big toe, and valgus is that tipped over position, that really turned over position of the big toe. And it can get extreme, all right? So because it's a hallux valgus problem, because it's an alignment problem, then sometimes treatment comes down to realignment and not just taking off the bump. If people don't believe me that it's not just a bump when they look down at their own foot, take a look at an elbow, right? When you bend your elbow, you see a bump. The easiest way to get rid of that bump is not to cut off your elbow. The easiest way to take care of that bump is to straighten out the crookedness, and suddenly that bump goes away. So it's an alignment problem at least as much as a bump. Very rarely is it just a bump. Now these alignment problems do tend to get bigger as time goes by, but I'll tell you that it doesn't always mean that they tend to hurt more. So speaking personally, I had my grandmother lived 93 years, probably 83 of them were with her big toe pointing over, and she finished those 93 years with her big toe sitting underneath, not just the second toe, but the third toe too. It was a sight to behold, and she had no pain as long as she was wearing shoes roomy enough to accommodate her toes. So it doesn't always hurt. But when it does hurt, we do try to distinguish between pain from that bump and pain involving the whole joint, which can kind of be a signal that the whole joint is irritated or that there may be some arthritis going on. Usually we can get a handle on that by just asking people to be patient, find shoes that are accommodating, find shoes that are comfortable. And there is a wealth of little gizmos and gadgets. I tell people, try to set aside a $30 gizmo budget and you'll find a pad or a brace or a spacer or a cushion or a silicone gel gizmo that can really make your foot or your bump feel better. But I do want to mention there is no evidence, at least in the published literature so far, that wearing one of these bunion trainers or anything else is going to change the alignment of the big toe once you take it off. So there's only one way to realign the toe, and that's to hire somebody like me to do that surgically, which it often doesn't come to. So when it comes to realignment, you can see that the toe is a little bent, and that angle between those two long metatarsal bones can splay out a little bit. And the treatment is can involve not just realigning the big toe, but actually realigning the whole forefoot. And there are a lot of different ways to do that that are sort of outside the scope of today. But it can involve realigning and fusing a loose joint. It can involve cutting a bone and shifting its position to make everything straight and happy again and biomechanically sound again. And this is just an X-ray of 2 different approaches to straighten out that crooked big toe, that hallux valgus. So let's move further up the foot. We're now into midfoot territory and arch territory. We call it pes plano valgus, which is a fancy Latin way of saying flat foot. People may use the word pronation. People may hear the term arch collapse, and sometimes it is that, sometimes it's not, but that's getting a little semantic, so we don't have to dwell on that. But it's really common. Probably about a quarter of adults, 25, 26%, have some degree of flat foot. Much more common in kids and adolescents. Part of that, though, is that's just the way the human foot grows. It doesn't start out with as much of an arch as it ends up with. So people who simply have a kicked in flat foot don't need to worry about it if they see it in their kids. Often that's flexible, it's painless. And the good news also is people who have an adolescent flat foot that doesn't hurt are no more likely to become adults with a painful flat foot than anyone else. So there's no good correlation between the shape of your foot as a kid or an adolescent and the shape of your foot as an adult in terms of something that's painful. And the reason is we think because kids just don't have degenerative conditions of the foot and ankle the way we adults have. So why does it hurt? When can it hurt? Well, the very common reason why a flat foot hurts is because the soft tissues are not doing their job holding up the bony structures of the foot. Remember, it takes a lot of weight and there's a lot of strain on these tissues here. Most commonly, a tendon on the inside part of the ankle called the posterior tibial tendon. Most people have heard of the Achilles tendon. We'll talk about it a little bit later. But the second strongest tendon in the human foot, and arguably the strongest for holding up the arch, is the posterior tib. And it's on the inside of the foot where that left arrow is. And many people with a flat foot feel a fullness and a tightness and a heaviness and a strain in that inner area of the ankle. And that's a sign that the tendon is wearing out, it's diseased, it's thick, it's surrounded by fluid, it's stretching, and it's just not doing its job holding up your arch when you stand or pulling up your arch when you're trying to propel yourself to the next step. If that flat foot is quite extreme, and you can see here that this patient, when you're looking from the back, you can see they have something, I'm going to get technical here. It's called the too many toes sign. That's actually what we call it in the industry. And you can see looking from the back, their toes are sticking out from the side because their foot has collapsed inward. And if it collapses inward this much, you can start to get pain actually on the outside of your foot, which doesn't make sense. If I have a tendon problem on the inside of the foot, if my arch on the inside of the foot is gone, how come it hurts on the outside of the foot? And the answer is often because you have impingement on the outside of the foot. You can see how that heel bone is tipped way, way outward, and can even, if you look at that little inset picture on the right, it can lean against your ankle bones and pinch either direct bone on bone or pinch the soft tissues that are between there, just like biting your cheek between your teeth. So getting rid of that pain, whether it's surgically or non-surgically, depends on realigning your foot and decompressing that outer part. So another way that this malalignment can happen is not just from the hind foot. The bones, and you'll have to trust me on this X-ray, in the hind foot are normally aligned. But if you take a look at this X-ray here, there's a very important joint in the middle of the foot, the upper part of that big toe metatarsal, that long bone here, and that joint has to stay strong. That joint doesn't need to move. That joint needs to stay strong. That joint is an evolutionary artifact and we don't need it anymore. Most of the time it's not a problem, but if it does stretch out and get loose, you can see that that sway back deformity can cause a drop of an arch for different reasons. Most of the time this can be managed without an operation because reconstructions can be kind of a big deal. But even if it did come to surgery, the outcomes for treating this problem are typically pretty good. Non-operative success is great, 85% or more, particularly if that tendon is still intact and still functional and the muscle is still working. but it can be a little inconvenient to get there, and it can be taxing to people's patience because it can take some time. First, sometimes things in the shoe aren't enough to really control what your foot is doing. Just putting an arch support in there may not be enough, particularly if you have a little extra weight on you. That power will overcome that little soft insert or even a hard insert, and you'll need to get more control of the foot and ankle with a brace. These braces can be cumbersome, but some people don't mind that if it means avoiding a big surgical experience. So we do know that if people can lose weight, it helps. People can do bracing, helps, and there's a whole host of physical therapy and other conservative care that can make this pain get much better, if not go away completely. But you got to be patient with it because it can take several months to really get on top of it after many years of this thing kind of coming into the foreground. Surgical treatment, if it comes to it, is a long process, but there is a good outcome waiting at the end for you if it does come to that. So moving further back from the flat foot, we're going to talk about the Achilles tendon for a minute. Now we're going to move from female predilection to male predilection. People who are genetically male tend to favor this problem 2 to 1 for reasons that we're not 100% sure we understand. It is common in runners and weekend warriors where the tendon can actually tear, and as many as 1 in 5, 1 in 6 people can have this problem. It typically comes in 2 varieties, 2 flavors, as I call it. There's one called insertional Achilles tendonitis. The attachment of any tendon to a bone is called the insertion. And you can see that bump on that left-hand picture there that the arrow is pointing to. That kind of classically has a nickname, the pump bump, because when you wear tight high heel shoes, pumps, that heel counter pushing against your heel can really irritate that. But pretty much any stiff shoe can bother that. So opening up the back of the shoe or wearing open-heeled shoes can help. That bump is not the tendon. That bump is a bone spur, as I'll show you. And then the other version, the other flavor of tendonitis is disease of the tendon proper, the rope before it attaches to the heel bone. And this is a pretty extreme example of a swollen tendon surrounded by fluid, longitudinal splitting and tearing, and almost like unraveling in the long direction of a rope. And that's a disease of the tendon itself. Stepping back to the insertional version, you can see degeneration of the tendon attachment where that arrow is associated with a big calcification there. Sometimes that bone spur attaches to the heel bone. Sometimes it's a separate calcification. And it's a similar degenerative process to other places where tendon attaches to bone and become angry with you. A very common one is called plantar fasciitis. Most people talk about a bone spur or a heel spur. This one down at the bottom left is usually the one that they're talking about. The spur itself, and I try to tell this to people, is not what hurts. It's the diseased tissue next to it that stimulates the bone to grow a bone spur, trying to relieve that strain from the attached gristle. In that case, the plantar fascia. In tendonitis, it's the tendon itself. Also, people have heard of tennis elbow. We call it lateral epicondylitis. But if you cut down on syllables, it's tennis elbow. And you can see this x-ray here has a calcification also right where that tendon attaches to bone. I tell people tendon is not smart tissue. It can just calcify. That's pretty much all it can do when its attachment gets upset. The non-insertional kind is really a blood supply problem. It's not a closed artery or anything like that. It's that the blood supply for the tissue is not quite rich enough sometimes for the mechanical demands placed on this powerful tendon. It sees some of the greatest strain in the human body, and there's a richer artery. You can see the one on the right that supplies the muscle and the upper end of the tendon, and then another one that attaches, that goes to the attachment. But there's a smaller artery that sends teeny little vessels to the mid portion of the tendon. And anytime there's a relative lack of blood supply, which is a normal arrangement, it's not a disease state, but that relatively sparse blood supply, which happens in several places in the body. It's called a watershed zone. Probably we stole that from geography or archaeology, but watershed zone means less blood supply into that tendon. And we think this process of repetitive microscopic tearing and then healing and then tearing and then healing creates a disorganized scar tissue. If you were to look at this tendon under a microscope, what we call histologically, it just doesn't quite look normal anymore. And our challenge together is to try to figure out how to salvage a tendon, which is kind of trying to give up. And the good news is it is amenable. You can change the personality of that tendon, that blood supply, reorganize those tendon fibers, those tendon cells, and make it hurt much less. Although that thickening of the tendon often sticks around even after it doesn't hurt anymore. So treatment for Achilles tendonitis, the insertional variety, there is physical therapy, especially if you have a tight muscle belly back there, the gastroc or the tight Achilles tendon. Stretching is critical. There are heel lifts to get that bump out of the way. Get stuff not to push back there, but sometimes, especially when there's a big spur, it does come to needing to get a guy like me to do a surgery to clean out that diseased tendon, remove that calcific debris, and then we have to reattach that tendon to the bone with a little anchor or something we screw into the bone, tie that back together. 85, 90% good or excellent outcomes. But a long recovery, because obviously you can't walk after detaching that tendon. You have to let it heal back together again. So we try to get you happy without surgery first. The non-insertional kind, arguably better responding to physical therapy. And there are some very well-described techniques to get you better if it hurts. There are surgeries for it, all different kinds. Be careful when you're having injections, because those injections can lead to a tendon tear. Just to make sure if anyone's going to put an injection in there, they know exactly what they're doing. So moving further into broken ankle, this is kind of like the movie star, right? A lot of exciting stuff, and everybody can see what a crazy ankle looks like, and broken ankles and broken bones look like. So we're going to show a couple of those pictures. So the ankle joint, the talocrural joint, is where three bones come together. The main leg bone is called the tibia, and that bears anywhere from 5/6 to 9/10 of your weight, depending on the biomechanical study you believe. So that's that main leg bone coming down, called the tibia. And then that smaller outer leg bone, called the fibula, creates that ankle mortise. It's called a mortise because it frames that talus bone, that ankle bone. And you can see here on this graphic, this is a picture of a mortise and tendon joint. Specifically, this is called an open mortise and tendon. And you can see those pieces of wood framing that inner piece of wood. And you can imagine that if either of those edges were to break off, that middle piece would potentially, anyway, no longer be contained. I'm going to limit discussion here to breaks of the tibia and fibula. The inner part of the tibia called the medial malleolus, the outer part of the fibula called the lateral malleolus. Just to keep it clear, I'll call it inner and outer. There are lots of other kinds of ankle injuries, including an injury of the talus, which is about 65, 67% covered with articular cartilage. It can be a bigger deal. So we'll just talk about sort of the classic inner and outer ankle bone fractures. So you can see here, in addition to the two bones, there are these two ligaments. There are actually many more, but I'll touch on these two ligaments and how they're important. That inner ligament is called the deltoid, and that upper outer one there connects the fibula and the tibia together. And that's important too. I'll show you how. So you take a history when you're talking to somebody, right? We're not just photographers and carpenters. We actually are doctors, and we talk to people, and knowing how something happened is kind of important. You can see that these two kinds of injuries can have potentially very different personalities, and the amount of energy that anything, including an ankle, absorbs can really define the personality of a fracture and how it behaves and what else may be injured. And you can imagine which of these two was more of a catastrophic event. So to be clear, this is a joint injury. A broken ankle is a joint injury, so it's not like breaking the leg or the forearm or the upper arm bone, where you can connect the two ends or let the body connect the two ends and the joint on either end is okay, right? This can cause joint damage. This can cause stiffness. It can increase the risk of arthritis, and that's why we take them so seriously, and that's why we sometimes have a little bit of a lower threshold to getting surgically involved, because we want you guys to be well long into the future and not just for the next couple of months. So there are reasons we want to operate on these injuries in some cases, and we look for these kinds of criteria, right? Number one is, did the fracture shift out of place, right? It's an unforgiving part of the body, a joint is, so you have to make sure the fracture didn't shift out of place. Did the injury pattern create an unstable joint itself? Will that talus bone, that ankle bone, stay put, right? Did the fracture involve the joint surface Fractures that involve the joint surface, especially those that move out of place, less likely to heal. And if they heal, if they create an incongruency, a step off, a rough, jagged area, that can be a problem for future smooth function, right? And then finally, is the fracture alignment stable? Just because it looks today, we have ways of predicting whether or not it may not look good next week or 2 weeks from now. So that's another reason to maybe stabilize it with more than just a cast. So here's an example of what's probably a stable ankle fracture. If you look close, you can see a teeny little crack. That crack is below the level of the joint, so it probably didn't tear any ligaments along the way. This is one we'd probably treat in a boot and a cast and let you walk on it and move it a little bit early. They're not all like that, right? So if you take a look at this picture, you can see it looks a little bit different. This is a fracture of the inner or medial ankle bone. You can see it shifted out of position from where it's supposed to be. You can see it does go into the joint, so that joint fluid, like Vaseline on two pieces of wood you're trying to glue together, will keep those pieces separate. They may not get sticky, and they may not generate that scar tissue that allows bone to form. So that's a fracture that we would recommend surgically putting back into place and then holding with some orthopedic hardware to let the body do the healing for you. Moving over to fractures, both sides can break at the same time. Unfortunately, this isn't rare. Bimalleolar is the word we use for this fracture. In other words, both sides broke. And this is something where we would certainly want to talk to you about an operation to put these pieces back together, because even if we were to try to move things around, it's probably just not going to stay put and heal the way you're going to want. This is an interesting one, so you can compare this to the previous one. So you can see that outer ankle bone broke, and you can't see anything else that's broken. So what's going on here? And it turns out this is an injury at both sides. If you take a look here, that deltoid ligament goes along with that broken ankle bone, and you can see that deltoid ligament, that inner ligament tore, right? So even though nothing broke on that side, it's the equivalent of something having broken on that side, and that allows that talus bone to move over in that direction. And once that bone comes out from underneath your leg, we really can't leave it like that. So that's something, again, where we probably want to talk to you about surgically putting things back together and holding it there so you can do well into the future. And then finally, here's another interesting one, which even some orthopedic surgery residents don't quite recognize early on. There's nothing broken here. I don't see anything broken. I bet no one here can see anything broken. In fact, the fracture is there. It's just way north in that fibula bone, that little ankle bone, the outer leg bone, up towards the knee, right? What happened was nothing broke, but when this person turned their ankle, not only did that deltoid, that inner ligament tear, but that syndesmosis, that connection ligament between the two leg bones tore too. And that allowed this entire assembly to move over to the right. This doesn't require fixation of a fracture, but this does require a guy like me to put it back into the place. It's almost like a dislocated joint. We have to put it back into place. And then there are implants we can use to hold these bones together while your body does the mending. So important things not to miss, even if nothing's broken. So if you break your ankle, whether you do or don't have surgery there, it doesn't always go the way we hope. There are risks of complications, things we can't control, like how high you were hanging from that barn window over there, and things we can try to control, like cigarette smoking, for example. Cigarette smoking, it turns out, is associated with a lot of potential problems in musculoskeletal medicine. It's associated with back pain, it's associated with arthritis, and it's associated with a delayed healing of a fracture. This is true. I'm not just making this up to get people to quit. If you break an ankle or break any bone, particularly in the ankle where there's less oxygen in the blood down there, you have twice the risk of not healing even a routine fracture just because of the smoking habit. And that's dose dependent. So the more you smoke, the higher that risk is. So if you take a lot of, oh, I just got a little warning there. Here we go. So if you take in a lot of nicotine, you're increasing your risk of complications. And if you have surgery, you're increasing the risk of a wound healing problem too. So we love to get people off of that stuff before a surgery happens or immediately when we see an injury. And that's all sources of nicotine. Smoking gives you more carbon monoxide, but vaping and gums and patches and all those things, you still have a source of nicotine, so that's still the problem. And I'm not going to kid you. I'm aware of how tough the challenge is, but it doesn't make the physiology of it any more ignorable. Other problems, diabetes, which we think affects the blood supply, and bone formation ability has a role here. There are other things which can increase the risk of things not working out, but we want people jumping for joy. We don't want people limping into the future. We don't want to have to deal with post-traumatic ankle arthritis later on in life. So we try to treat these aggressively and get you happy early so you can move on. So I think that pretty much wraps it up for my talk. I just wanted to give you some resources to read more about it. These are my two professional societies, my primary professional societies. The American Orthopedic Foot and Ankle Society is a foot and ankle society for orthopedic foot and ankle surgeons. You can go to footcaremd.org, and it's a patient-facing experience. So it's got some customer-oriented, not doctor-oriented information. And there's also the Academy of Orthopedic Surgeons, my professional organization, orthoinfo.aaos.org. And they'll steer you in the right direction. So thank you so much for bearing with me and listening to me talk to you a little bit about some common things. I think we're going to open it up to some questions here, and I'll put the splash screen back on. So if you would like to call for an appointment or want to learn more about what we can offer you at the Cooley Dickinson Orthopedic Surgeon Sports Medicine, then we're happy to just kind of keep that information floating for you so you can write it down. So thank you so much. I think we have, I'm going to look over here. I think we have some questions. Yeah.
Question 1. As a stroke survivor, I have curled toes. Historically, I've been a patient at Spalding in Boston. Can I get help locally, especially to discuss Botox for my feet?
That's a great question, and I'm very sorry for your history there. The claw toe problem is definitely treatable, and I absolutely have seen people with this problem. This is a neuromuscular problem, which is not something that I really touched on, and we see it not only in stroke survivors, but people with even congenital neuromuscular conditions, cerebral palsy and other problems. In terms of Botox, this is not within the scope of most orthopedic surgery practices. I don't offer Botox. Most people don't offer Botox in orthopedic surgery. There are physiatrists who do offer Botox. You can call our number. We do have a physiatrist on staff. As a new member of the team, I can't tell you for sure whether she offers Botox, but that service is available locally. I know that to be true. And there are practices that offer Botox. I would encourage you to talk to your primary care provider locally to see if you don't have to go all the way out to Boston. Yeah, we have another question.
Is a bone spur the same as a bunion?
Well, that's actually a good question. Bone spurs can happen anywhere, right? Anytime you have joint arthritis, you can have a bone spur. You can have a bone spur in your shoulder. You can have a bone spur in your thumb. Anytime a joint is inflamed chronically and wearing out, you can have a bone spur. So certain kinds of bunions, degenerative bunions, bunions where you also have arthritis in that joint, can definitely have a bone spur. But typically the answer is no. And most people who say they have a bone spur in their foot, they're talking about that bone spur in the bottom of the heel that I showed you earlier on.
I broke my ankle 5 years ago and had surgery.
Oh.
Having lots of pain and trouble walking despite the hardware in my ankle. Can anything be done?
Well, that is a common problem and a great problem, and hard to know exactly why your ankle hurts. Sometimes it's as simple as the hardware hurting, and that needs to come out. Answering that question is kind of like saying, my car is making a funny noise, can it be fixed? You really need to kind of dive in and find out why. And I'm absolutely somebody who can take a crack at that. So please come on in, we'll take a look at your ankle and figure out why it hurts. Sometimes it's a difficult problem to solve, but sometimes it's pretty straightforward. Sorry for your experience, but maybe you can be better.
Next question.
Pain
on the top of my foot when walking or hiking. It feels like a cramp. Could this be a stress fracture?
Yes, it could. It could also be a whole number of other things. So come on in and see us. We can certainly try to figure that out. It can be arthritis, it can be tendonitis, it can be a stress fracture, and it's probably not something that you need to be too alarmed by. We'll dig into it together.
Can you talk about extensor tendonitis, and is there a connection between this condition and bunions?
Probably not in the way you may be thinking. The extensor tendon to the big toe can be malaligned and contribute to malalignment of that big toe. Hallux valgus, we talked about it. But typically tendonitis is not part of that unless you have a much more complicated thing going on. There are tendonitis problems of the foot and ankle, but not typically associated with a bunion.
What's the best prevention for foot and ankle injuries for runners?
Play chess. No, I'm just kidding. Nintendo. No, I'm just kidding. So how to prevent foot and ankle pain, was it for runners?
Injuries.
That's a fantastic question. Usually it doesn't involve seeing a surgeon like me, but seeing a musculoskeletal specialist, whether it's a physiatrist or a sports and exercise medicine specialist, and there are many good ones out there. A lot of times it has to do with slow progress towards distances, respecting symptoms and cutting back until they're resolved, because reaching higher distances often involves plateauing and stabilizing and plateauing and stabilizing, having good support. This is my personal bias. I'm not a fan of Vibram toe shoes. I've seen a lot of stress reactions and stress problems from those. And in terms of conditioning, absolutely don't neglect dynamic warm-ups and cool downs, right? You want time, 10 minutes, 15 minutes of active range of motion, getting the blood flowing to the tissues. They will increase their stretch, increase their compliance. I can't tell you how many people I've seen for torn things and dislocated things who just hit it hard without giving enough time to warm up. So that's just kind of the nickel tour of trying to keep yourself healthy when you're doing impact athletics.
Can you talk about the recovery time for someone who has surgery for bunions?
Sure. Unfortunately, it's not one answer. If you're that rare person who really literally just has the bump, you can take that bump off and be walking the next day. If you're talking about somebody who needs a midfoot fusion because that arch collapsed and was incompetent, or you need bony realignment surgery, a lot of times you do ask you to be at least partial weight bearing, if not fully off of it, for a good 4 to 6 weeks. And that really does depend on what's done or whether it's being redone from a prior effort. I will tell you that people in my line of work in the foot and ankle surgery community are aware of how inconvenient it is to be off of the foot, and we're working on new techniques and new implants to try to get people walking earlier. The foot likes it, the joints like it better, and recoveries tend to be quicker. Pretty soon we'll be offering minimally invasive surgery through tiny little poke holes rather than more open incisions to realign the toe. And we also think that it'll be associated with a quicker recovery also. So it's a great question.
Are there any exercises to relieve or eliminate Morton's neuroma?
Exercises? No. Sorry. But there are other ways to relieve a Morton neuroma. Absolutely.
Such as?
Well, we talked about some of them. It can be a pressure problem. So getting pressure relieved from the ball of the foot. We talked about that insert to kind of translate some pressure and partially offload the ball of the foot. If it's associated with toes curling up and pulling that nerve up into that ligament, then little devices to help stretch those toes and pull those back down so they're not draping that nerve off the bottom. There are cortisone injections, which can be very helpful. So you don't necessarily need surgery. But there's not really a whole lot of good evidence that physical therapy and exercises in general will help. The first thing I would do is make sure that that's actually what you have.
How do you differ from a podiatrist?
It's a great question. I'm not a podiatrist. Podiatrists have different training. Podiatrists have a DPM degree, so podiatrists don't go to medical school. They go to podiatry school. Orthopedic surgeons have an MD or a DO degree. So we went to medical school or osteopathic school where we learn about the entire human body. After that, orthopedic surgeons spend 5 years or more doing musculoskeletal surgery. So we learn all about the musculoskeletal system, how to handle bone, how to handle those tissues. And then an orthopedic foot and ankle surgeon such as myself, although you don't have to have done a fellowship, does an extra year in orthopedic surgical foot and ankle surgery only. So we spend an extra year dedicated to foot and ankle surgery. A podiatrist may or may not do a surgical residency after podiatry school and have other area of expertise which some orthopedic surgeons may not have, like pedorthics and fitting of orthotics and doing soft tissue work around the foot and ankle like corns and calluses and ingrown nails and other things of that nature. But I'll tell you that there are plenty of excellent surgical podiatrists out there. When I did my fellowship at Duke University, we actually had a couple of surgical podiatrists on staff. Many states, I think including Massachusetts, will limit the scope of some podiatric procedures. I'm not sure that podiatrists are doing ankle replacements in Massachusetts, although they may well be, and I will certainly defer to the podiatric community on that. But there may be a difference in scope of practice there, and certainly a difference in terms of scope of privileges that are sought by a podiatrist who's working in your area. So there are some differences there, and I can only speak specifically to my own professional group.
I think
there is a lot of overlap, I'm sorry, but there is.
I think that corns, which are on the outside of my feet, are a product of flat feet. What can I do to keep these corns from returning after cutting the calluses down?
Good question. So corns are a product of pressure, okay? Just like the calluses on the tips of a guitar player's fingers, corns are a product of pressure. So if you can relieve the pressure, you can relieve the rate of recurrence of a corn. A corn on the outer part of the foot is uncommonly associated with a flat foot because the arch drops in and you're bearing more weight on the inner part of the foot. But if you have a corn on the foot, getting the pressure off of the foot by wearing roomier shoes in that part, or getting a pad, and a lot of people want to put a pad over a corn, but I think it makes at least as much sense to put a pad around a corn, like a donut pad, a strong adhesive pad which surrounds the corn so there's no pressure directly overlying the corn, and that can reduce how fast that corn reaccumulates. Yeah, so it's a pressure problem. In rare cases, you actually have to do bony surgery to relieve or reorient the bone so it doesn't apply pressure to whatever's pushing on it, but it usually doesn't come to that.
Can you talk about the use of shoe inserts for bunions?
In my opinion, there's very little role for that. Having said that, if you have a big hallux valgus, right, not a bunion bump, but a big toe that's moved over, as I mentioned, that big toe moved over, especially if it's a whole midfoot metatarsal big toe alignment problem, then that whole ray from the midfoot down to the tip of the big toe is not doing its job bearing your weight. And if you're having foot pain from that, then having a shoe insert, which gives back the responsibility of that big toe to bear weight, right? It lifts up underneath the inner ball of the foot or relieves pain from the outer ball, relieves pressure from the outer ball of the foot, then that can make your whole forefoot more comfortable. But just the bunion itself is not really a whole lot of role for an orthotic, especially an expensive custom orthotic, unless there's a bottom of the ball of foot pressure problem that can be addressed.
I had an unsuccessful surgery for a talar OCD.
Oh.
My surgeon says there's a 15% failure rate. He suggests the same surgery again, and does that make sense?
Yeah, that's a hard question. That's a little outside the scope here. That's technically not an ankle fracture. That's a damage to the cartilage in the talus bone, which you may remember from the ankle fracture slide. And those are really difficult to treat sometimes because you're talking about a specific area in the ankle joint that's basically trying to disintegrate. I really would need to know the details of the problem to answer your question smartly and usefully to you. A lot of times we'll try to treat them with a simple ankle arthroscopy, which is minimally invasive. Through small incisions, we'll put a little arthroscopic camera and a fiber optic camera and an instrument, try to debride it, clean it out, stimulate it. It's the right thing to try, but certain types of lesions or characteristics of lesions are more or less responsive to that kind of first pass of surgery treatment and might need a lot more done. So, yeah.
Could you make some recommendations for plantar fasciitis?
I'm not a super duper expert in plantar fasciitis. It's not a big part of my practice. But I can tell you that the primary treatment for plantar fasciitis is a combination cocktail of stretching and patience. It takes weeks to months, more like months, to get plantar fasciitis to feel better. once you make sure that that's really what you're suffering from, plantar fasciitis gets better with stretching. In fact, usually it gets better on its own if you give it 12 to 15 months, but most people don't want to wait that long when they're miserable getting out of bed the first time. So a group out of Rochester actually described a protocol of physical therapy, and that's been widely adapted, which stretches the bottom of the foot specifically, and that's been shown to do a little bit better job in getting people's plantar fasciitis to feel better than just stretching out the Achilles tendon, which is also an important thing. So it's stretching, and everything else is extra, whether it's a night splint to keep the foot stretched while you're sleeping, anti-inflammatory medications, the silicone gel heel pad to reduce the shock there. Some people like a frozen water bottle to roll on. There's all sorts of stuff that's been described, even injections of various things, although I would never recommend that first. So that's kind of my dime tour of plantar fasciitis for you.
Are there other injections that can help ankle arthritis, such as a visco supplementation?
Great question. The answer is the evidence isn't in yet. Steroid injections can unquestionably help ankle arthritis. It's temporary. The cartilage is wearing out and you can't put it back. There's no way to put cartilage back when the whole thing is just worn out. Just like that's true of the knee and hip and other joints that have a lot of arthritis. The only joint where there's decent evidence that visco supplementation, these gel shots work, is the knee. There are some papers which talk about it working in the hip, and a couple of papers which talked about half doses for the ankle, but the evidence isn't really in yet. And the syringes can be expensive, and as soon as insurance companies find out that there isn't a whole lot of evidence to support something, they may not reimburse for it. So we try to look to other means. Gel shots is not a mainstream thing to offer, unfortunately, for ankle arthritis.
Someone here writes, I had 2 cortisone shots in PT for plantar fasciitis, and it did the trick.
Yeah, absolutely. So we agree. It certainly can work. Yep.
What is your recommendation for over-the-counter orthotics?
Well, there's an orthotic that I tend to recommend. I tend not to love the ones that you just buy in the drugstore because it's confusing. They may not directly treat the problem that you're trying to treat. They have fancy colored rubber and they make a lot of claims that aren't really substantiated. There's a brand called Superfeet, which some people believe in, which try to get at alignment or presence or an absence of an arch or overabundance of an arch. I tend to recommend ones by a company called Atrex, A-E-T-R-E-X. They have a line called Lynco, L-Y-N-C-O. And they come in different materials and different designs to try to help foot and ankle problems. There's a company called DonJoy. It's the only one I know out there for a super high arch foot with ball of the foot pain. It's called the Arch Rival. It's a cute little name. But beyond that, I would probably tell you Superfeet or the Lynco orthotics. Once you get outside of there, you're looking at expensive custom orthotics. But I will say that some physical therapy departments, including ours at Cooley Dickinson, do make cost-effective orthotics where you don't have to have an extremely expensive one if there's a cost concern and you have a unique need that a commercial device might not address. So we can always take a look.
What causes a burning feeling on the pads of small toes after walking for a while, say for an hour?
Yeah, well, that sounds kind of like metatarsalgia, probably overload. And a lot of people have really interesting and unique ways to talk about pain, and a burning pain is a legitimate way to describe pain. The word burning often suggests neuropathy, so I couldn't swear you don't have a neuroma. I also couldn't swear if it's kind of more diffuse and in both feet that you don't have some sort of a generalized peripheral neuropathy, but it could just be overload pain and it could respond to metatarsalgia, just offloading, getting a good shoe inserter or something soft and comfortable. Yeah.
Question here about what wide shoes are good for running.
I try not to get into recommending a particular brand. So if you can't go out shopping because of coronavirus, there's some online retailers that offer free shipping and free returns. So pick something that your friends have told you that works, and send it back until you find something that's good for you.
What can you do for a bone-on-bone injury? I had surgery 7 years ago and was doing much better. Now I can barely walk.
To answer that question, I'd need to know what bone on what bone. So unfortunately, I don't have a good answer for you. In the foot and ankle, many times a joint fusion is an option depending on the bone on bone. Joint fusions are typically pretty well tolerated. At the ankle joint itself, there are ankle replacements. I do offer ankle replacements. So if it's the ankle, that's certainly something to talk about if you're a good candidate, but we need to know what joint you're talking about.
Here we have time for just a couple more questions.
Sure.
Are there stretches I can do to help with heel pain?
Yeah, the plantar fasciitis stuff that we talked about is a great way to go.
My teenage daughter wears flip-flops all the time. I tell her that wearing flip-flops are not good for her feet. Is there any truth to that?
Flip-flops are terrible. No. I mean, I wear flip-flops sometimes, although my daughter wants me to wear matching Birkenstocks, so I like those. But flip-flops by themselves aren't terrible. I mean, that's I wouldn't tell somebody not to wear flip-flops any more than I'd tell somebody not to walk around at home barefoot. If you're doing anything more athletic, if you're doing any cutting or pivoting, if you're doing any running, I would stay away from flip-flops, not necessarily because the surface you're on is bad, but because your heel isn't contained, your foot is not contained, and you can slip out of the flip-flop and roll your ankle and hurt yourself. So it's not an exercise shoe, but it's perfectly legitimate for walking around on the beach or taking a stroll in the neighborhood. That's okay.
We'll wrap it up with this question here. How do you know if, this is another orthotics question, if they'll work for arch issues or bunions before you buy them? Is there any way to know?
Other than seeing somebody trained in orthotics, and it doesn't have to be me. In fact, typically it's not. By the time somebody sees me, they've often seen other experts in orthotics, but there are orthotists who you can consult on, or other musculoskeletal specialists about orthotics to see if the problem you have in your foot is designed for the orthotic that you're considering. And I think it's a good question. To be fair, I've seen people who, have like a metatarsalgia problem, and they have a very expensive custom-made orthotic which doesn't do anything to offload the forefoot. Or they have an arthritis problem and they have a really floppy, flexible shoe insert that's not going to be stiff enough to protect the bending stresses of the foot. So if there's any question, see a professional and, get an opinion on a good design before you spend a lot of money. So I think that's the last question we have time for. And I hope it's been interesting. I don't know if you were able to tell, this was my first web conference, and I hope it was interesting and maybe a little bit fun and maybe a little informative. And I want to thank, again, Cooley Dickinson for putting this together. It's a terrific place to work from my perspective, and I've already met so many terrific patients and colleagues, and I really look forward to it. And I want to thank also Dr. Fallon again. In fact, I'm going to turn it back over to him, and he can do things to wrap up. And perhaps I'll see you around the neighborhood. So take care, everybody, and be well. Yep.
All right. Thank you, Dr. Hoffman. That was a great talk. Appreciate your time. Thank you, everyone, for listening. I hope you got something out of this. Just a reminder, we did videotape this, and we'll be sending out a link in about a week or so. Also, a quick reminder, we are accepting new patients, especially Dr. Hoffman, but all of us. So if you have any questions or would like to be seen, just give us a call. You got the number there. As part of the Cooley Dickinson Safe Care commitment, we're doing everything we can to keep everybody as safe as possible. So please don't delay your care out of fear. And with that, I'd like to just say thank you very much for coming, and good luck and be safe.